Good day, everyone. I hope you are all well. This is Yasser from WHO, and we are going to initiate our today's discussion around pneumonia research priorities, which was conducted by Every Breath Count in collaboration with Malaria Consortium, Karolinska Institute, and UCL. Um, Before we start, there are some housekeeping stuff which I would like to share with you. Number one, that please mute your mic all the time and put your question in the chat for speaker and panelists. Today's agenda is we will start with opening remarks from myself very briefly about pneumonia problem burden and how we can improve it. And then Kevin and Karina will let us know about this work, which was started in November 2019 and was finished by this summer, and it's going to be published very soon. And then afterward, we will have a panel discussion around some of the key areas which highlighted during this research priority exercise. And lastly, Leith will give us a closing remarks. Sorry, I was muted. You are all well aware that pneumonia is the #1 killer of children in post-neonatal period, especially globally. We have around 600,000 pneumonia-related deaths in 2019. Not only in a post-neonatal period, pneumonia is also contributing about 150,000 deaths in neonatal period. However, during the last two decades, pneumonia-related deaths have been reduced by about 55%. Nevertheless, the burden of childhood pneumonia, morbidity, and mortality is higher in sub-Saharan Africa and South Asia than in other regions, with a slight increase in the proportion of deaths attributed to pneumonia in Africa. There is some important facts that 53 countries are off track in meeting the SDG target for under 5 mortality, which is at least as low as 25 deaths per 1,000 live births by 2030. And most of these countries are in sub-Saharan Africa. And data has shown us that pneumonia is the leading cause of death in these countries. When we talk about strategies how to reduce pneumonia morbidity and mortality, WHO launched in and UNICEF launched in 2013 Global Action Plan for Pneumonia and Diarrhea, which actually give us prevention of pneumonia and diarrhea by 2015. We commonly called it as a GAP-D, which provides a roadmap for national governments and their partners to plan, implement, and integrate services to reduce childhood pneumonia and diarrhea-related mortality. The framework is for GAP-D is protect, prevent, and treat. And we will learn more about these aspects from the research priority work, which is going to be shared with you very soon. Regarding the recent activities which WHO has taken to mitigate some of the risk around pneumonia death in children, we had started some of the conversation in interdepartmental level, at the headquarter level, at regional level, and at country level to evaluate the implementation issues and how we can improve them in the next few years. At the same time, we are also analyzing the data at the global level, at national and subnational level to identify the vulnerable population. And then the most important question is how we can reach that vulnerable population within a country. Lastly, we also synthesize the latest evidence around pneumonia prevention and management in children up to 9 years of age in order to improve the current guidance, implementation issues, and mitigate those risks, as well as what research we would like to need it in the next few years to prevent deaths from pneumonia. We conducted a consultative meeting last month where we asked regional partners at the global level, at the regional level, and at the country level, academia, as well as researcher to participate and share with them this latest evidence to see how we can improve the guidelines and the implementation of pneumonia strategy. And lastly, what are the key areas of research for pneumonia in childhood? Regarding research, we actually conclude four major areas. First, we still need basic clinical research on presentation and management of pneumonia in children 5 to 9 years of age. Secondly, we need more research on the use of technologies to improve diagnosis of pneumonia, including laboratory investigation, biomarkers, and others to improve current diagnosis. Third, we still need some implementation research, including behavioral research, to improve the coverage with quality of care of various intervention, considering demand and supply mechanism. And lastly, which is more importantly, is the evidence analysis of risk stratified management of pneumonia, both clinical like during the pandemic, such as COVID-19, and context specific also with other similar crisis areas. So to conclude, research priority exercises can help us reach the SDGs, but also need to consider how COVID pandemic has impacted health system, etiology, and epidemiology of childhood infection. With this context, I would like to ask Kevin and Karina to present the methodology and key findings of Every Breath Counts research priority exercise. Thank you very much. Over to you, Karina.
Thanks, Dr. Yassir. I'm going to go first. Good morning, good afternoon, good evening, everyone. My name is Kevin Baker. I'm just going to take you through the background and some methods. Dr. Yassir has already explained some of this, and I'll go on to just cover it briefly. Can I go to the next slide, please? And the next slide. Great, thanks. So as we've explained, and even some of the participants on this call wrote about in 2018, pediatric pneumonia often is a global cause without champions. Now in 2021, pneumonia remains the leading cause of infectious deaths, estimated at 672,000 in 2019 alone. And progress to reduce these deaths has lagged behind other diseases such as diarrhea, measles, and malaria, and without major investment will mean SDG 3.2 cannot be met. Next slide, please. Again, further challenges in the pneumonia funding landscape have been documented, as you can see from this work by Michael Head and his group, with the graph on the right there showing funding against DALIs in 2017, pneumonia right down on the bottom right. And in this work, they've documented that pneumonia is just receiving 3.5 billion compared to 42 billion of research funding for HIV. And Michael's research further shows that most of the funding is allocated to preclinical research. Adding to this, as Dr. Nassir said, the COVID challenges, and it makes securing funding for pneumonia research difficult, to say the least. Next slide, please. So, given these known challenges, the Every Breath Counts research group felt that one of the main purposes or activities when we came together in 2019 was to update the previous work that had been done in setting pneumonia research priorities. The work had last been done by Rudan and his group in 2011, and they had taken 400 research ideas and synthesized those into 158 research questions. In the meeting that we had in March 2019, which seems a long time ago now, when we started this work, we felt that there were other considerations that needed to be taken into account in this work. So the group thought that it would be better to have a more focused list of research priorities, which could better support securing future funding. The list should reflect what questions had already been answered. We needed to take into account the COVID-19 context. And then, as we talked about, thinking about grouping the activities under the GAP D themes, which is prevent, protect, diagnose, and treat, and then a cross-cutting category, so 4 categories. Based on these considerations, a protocol was drafted by a committee of 6 people and submitted for ethics review to the Liverpool School of Tropical Medicine. Next slide, please. So the group agreed to use the E-Delphi method, and using that method, there are 3 main phases, which I'll now just quickly go through. The first phase is around brainstorming, and that was where we went to a list of 300 experts sourced from existing Every Breath Counts contacts, social media, from the Global Pneumonia Forum that was in Barcelona a couple of years ago, and then also individual contacts. We initially then sought participants' consent and what level of engagement they'd want with all or some of the themes. Once this was achieved, they then received the existing list of research priorities made up of the Rudan list, plus some additional priorities highlighted in group meetings previously. We further asked respondents to provide some COVID-specific priorities that have subsequently become important. And all of these responses were then reviewed by the committee, duplicates removed and consolidated into one long list. We then went on to phase 2, which is narrowing down, and we sent this long list to all of the experts and asked them to further select their priorities from this long list based on 2 factors. First, the importance of the question, and secondly, if the question had already been answered. And all of these responses were then reviewed by a committee. The committee had a criteria that retained any priorities that were highlighted to be unanswered and important as selected by at least 50% of the experts. This allowed shortlists to be created for each topic area. And the final phase was then around ranking, where these shorter list of priorities were then sent to the relevant experts by topic area, and they were asked to rank them. The committee then collated their responses into a mean rank for each priority or item. Next slide, please. As you can see from this graph, we started in January 2020, once ethics approval had been received. We then conducted round 1 before having to stop activity due to the pandemic. We started data collection again in January 2021, and ranking was completed in the summer by July 2021. And as I say, a diverse data sources were used to create our expert lists, ranging from the mailing list, social media, the forum, and personal contacts. Next slide, please. Here's an example of how we narrowed down some themes relating to diagnosis and treatment. So this is in the narrowing down of phase 2. And as you can see here, we have 6 original themes, and highlighted 35 and 37. You can see that the 2 themes that were removed because they were unanswered or not important as selected by at least 50% of the experts. Next slide, please. So experts were defined as clinicians, researchers, technical partners, implementers, industry and government employees who have actively worked in the field of childhood pneumonia within the last 5 years. So we really wanted to get a very inclusive list of experts. We also worked hard to include representation from multilateral, bilateral, national governments, NGOs, research institutions, donors, and private companies. We also sought to have an equal gender distribution with a minimum of 50% respondents from LMICs and higher representation from the 10 high burden pneumonia countries. Next slide, please. The final ranking was calculated using a rescaled mean of the rank. As the 4 themes had different numbers of themes, originally we rescaled each to be scored from 0 to 25 to allow comparison, with a lower mean rank indicating a higher priority. We will present results stratified by current country of residence and academic versus non-academic participants, experts. And finally, we will present results classified using the 4Ds approach, and that's classifying them into description, delivery, development, and discovery. Thanks very much. So that's an overview of the methods. I'll now hand over to Karina.
Thank you so much, Kevin. So I'm Karina King. I'm an associate professor at Karolinska Institute and University College London. And so I'm going to go over the results and some of the key discussion points that we think were really interesting from this work. The next slide, please. And the next one as well. Thanks. So firstly, on the participants. So as Kevin said, we really were ambitious where we wanted to try and have as representative a list and a diverse list as possible. And we started out with a fairly good balance. So we had compiled a list of 370 pneumonia experts, but had obviously reached out to people through multiple channels. So that was just one form of who we were trying to reach. And we had gender balance. We had a good balance between researchers, so academics at universities versus NGOs, government and private actors. And then almost 50% balance between high income versus low and middle income country representation. As we went over the rounds, we were aiming to try and get a minimum of 50 respondents for each round. And we achieved that in all but the 3rd round, which was the COVID specific one. And instead of trying to do another drive, we thought time was more important. So we settled at having a lower response rate in round 3. But you can see that as we went over the rounds, we got less and less diverse in our representation. So by the end, the ranking was done more by high income respondents and lower middle income respondents, more by men than women, and much, much more by academics than non-academics than our original intention. Next slide, please. In terms of where everybody came from, so over those rounds, we had a total of 101 different participants. The countries in orange represent the countries where we had a named expert on our list that we reached out to directly. And in green is where we had respondents from. 2 really notable issues in this was we had no representation from Central and South America, even though we had most of those countries represented on our list of experts. So they were reached out to, but didn't partake. And the other big gap was we didn't have anyone from China take part, and Southeast Asia really didn't have much participation. The highest number of participants came from the US and the UK, followed by Uganda. Next slide, please. In terms of how we got to our final list, so our final list had 101 priorities on it. And we had started with a consolidated list from the Rudan paper, plus some extras that got added in during expert meetings. And we had, so at the beginning, you can see that we had 20 research questions under the protect and prevent theme. We had 25 in diagnosis and the fewest under treatment with 17. By the time we got to the end, we had the most in the cross-cutting theme, which went from 21 to 34. And the biggest shift had been in the treatment, which went from having the lowest to the 2nd highest number of priorities listed. The red boxes indicate the number of priorities that were taken out at each round, and the green represents the number of new questions that were added in. So these were those questions that people suggested and recommended, which we then consolidated and combined with existing questions to make sure that we didn't have duplication. In terms of the COVID specific round, you can see quite clearly that hardly any of the questions that were proposed were then removed. So only 6 of the COVID-19 questions that were put forward were taken out before the ranking happened. Whereas you can see in the previous rounds, quite a few questions had disappeared, particularly from the diagnosis and the protect and prevent themes. Next slide, please. So in terms of how this compared to the Rudan priority, so we're really keen to try and see if that prioritization had led to anything. So we took the top 10 priorities from the Rudan study and saw where they were in our current ranking. 8 out of the top 10 were dropped in our priority setting, 6 in round 1, so it's a typo on the slide, and 2 in round 2. And the 2 that remained in our ranking exercise actually came out in the top 10. So we have these 2 persistent research needs, as we're calling them. One, which will form the topic of our panel discussion this afternoon, which is around health system capacity, which was ranked 9th in Rudan's paper in 2011 and is ranked 2nd overall in our current study. And you can see that it's mainly because of importance. It's not that this question wasn't considered answered. It has been answered to some extent, but probably more reflects the need for continual data and continual information on this topic. The number 1 priority from the Rudan paper was the barriers to care seeking and healthcare access. Again, this scored high on importance, but low on being unanswered. So most people felt that that research question had already been answered, which would indicate a success of that priority setting exercise. Next slide, please. So what everyone's been waiting for, I think, is the actual ranking. So what came out number 1? We've presented these as the top 5 priorities in each research theme. So under prevent and protect, what came out as the top 5. And then in that 3rd column, you can see the overall ranking. The number 1 ranked research priority was to explore interventions to prevent neonatal pneumonia. So that came out as the top. I do want to highlight here that that was really a reflection of high income academic respondents. It only ranked 18th when you looked at low and middle income respondents only. So that priority is not necessarily a reflection of all of our participants. For the prevent and protect, 3 out of the top 5 priorities were related to vaccines. And it was nice to see that the 4th priority here around reducing air pollution was in there, given that was the focus of World Pneumonia Day this year. And in diagnosis, 3 out of the 5 priorities were related to the implementation of pulse oximetry. And the other 2 to do with identifying better biomarkers and rapid point of care tests to try and determine etiology. So really pulse oximetry and how we implement that in an effective way came out as a really big priority in this exercise. Next slide, please. For the treatment theme, the top theme was around barriers to providing oxygen. And I think what's really important when we look at the treatment theme is that most of the priorities in this section were not to do with new or novel drugs. They were mostly to do with using things that we already had access to. So better ways of using antibiotics, how are we delivering them? How can we use oxygen better? Where in the health system should it go? And really importantly, cost effectiveness came out in quite a few themes in this priority setting. So really a lack of data currently on what interventions are cost effective in pneumonia. And then finally on cross-cutting, this is where we had the only 2 COVID-19 questions that were retained. So you saw that we had a lot of questions included in the ranking, but very few of them featured in the top 20. The only 2 were looking at the impact on access to child health services, and then the long-term effects of COVID-19 infections in children for child health and development. No other COVID-19 questions featured in the top 20. Next slide, please. So I just want to highlight 3 points that I think are really key discussion points that have come out from this exercise. And the first was that there were really large differences in the priorities the ranking of priorities between high income and low middle income respondents. Just to note that this was also reflected between academic and non-academic respondents, with non-academic respondents prioritizing implementation research and kind of more practical questions, and academic respondents having a bit more focus on innovation. But this table shows in the overall ranking, you can see the overall rank for that priority amongst the top 5 in these subgroups, but in brackets, it's where it ranked for the opposite group. So when we look at the lower middle income country respondents, their top priority was to develop low cost combination and conjugate vaccines. And that ranked 27th overall, but only number 71 out of the 101 questions for high income respondents. And so those top 20 that we have, and I do want to reiterate this again as a limitation, do reflect a high income gaze more than a low middle income gaze where the majority of the burden is. And so I think this is something that we really need to be conscientious when we take forward these priorities, is how we frame the priorities for different groups of people. Next slide, please. The next was the focus on implementation and health systems research. Out of the top 20 priorities that were listed, 13 were related to descriptive research. So that's looking at things that already exist. So descriptive epidemiology and trials of existing interventions. Very few were to do with developing novel things. So very little discovery, which, as we heard from Kevin, really most of the funding goes towards discovery. Very few discovery questions were prioritized in this exercise. And notably, I think in the treatment theme, none of the top priorities involved new therapies. It was all about how to repackage and deliver existing therapies better and to the right people. So I think that shift from innovations research to health systems and implementation research was really important here. And next slide, please. And the final discussion point to bring out was just how COVID-19 played out. So we obviously took this pause in the research setting exercise because of the importance of COVID-19 and how we thought that would shift the health system and funding landscape. And when it came to it, very few COVID-19 questions were in the top, had been highly ranked. They were mostly low ranked, but retained in the list because they were deemed as unanswered, but not necessarily that important. And I think what's really important to highlight here, and that we've seen in this pandemic, is that a lot of the COVID-19 questions that come up really relate to general health systems issues, so general weaknesses and capacities of health systems. And so that was really reflected here, where a lot of the questions about COVID-19 had kind of been covered in our pneumonia research setting anyway. Next slide, please. And so finally, just to conclude, so kind of the key things that I think we want to bring forward from this is that many of the treatment, diagnostic, prevention, and vaccine innovations to deal with pediatric pneumonia already exist, but we need to get better at understanding how to implement them effectively with the right groups at what level of the health system, and trying to establish the cost effectiveness of those and clear effectiveness and efficacy of these interventions. The next was really the need to break through research silos and work across multi-site, multidisciplinary platforms. A lot of the highly ranked questions in the Rudan paper subsequently got funded through multi-site collaborative projects. So thinking about kind of seminal works like the PERCH study, that really addressed some of the top priorities in the Rudan paper. And many people then said that those had been addressed. So maybe that model of funding to take forward would be more effective at dealing with some of these research, especially persistent research priorities. But also we can see the top priority of neonatal pneumonia. We really need to break down that silo between people who work on newborn, maternal and newborn health and child pneumonia to make sure that we're working together effectively. And finally, I think what's been interesting was that a lot of things didn't come up in the priorities. So a lot of the major risk factors for pediatric pneumonia mortality, poverty, maternal education and empowerment. So a lot of these things that we know are very big risk factors didn't come up at all. So I think that leads to this notion that having good evidence, so knowing something, hasn't really led to effective policy or quality implementation. So it's really that need to harmonize this research agenda with national stakeholders to make sure that the evidence we're generating from the research community is actually useful and desirable and usable from the stakeholder perspective. And again, this comes back to the issue that we had in engaging enough people from outside high-income academic institutions. Despite trying quite hard to engage that group, we still didn't manage to get as representative a group of respondents as we would have liked. So I think the next steps need to take that into consideration. And so that's where I'm going to stop on the conclusions and hand back over to Yasir for the panel discussion. But I hope that's given lots of food for thought for everybody in the audience for questions as well. Thank you.
Thank you so much, Kevin and Karen, for giving such a beautiful presentation, explaining the methodology, results, and key discussion points. We can wait for a minute to see if there is any clarification questions for Kevin and Karina. Otherwise, we move to a panel discussion then. If you have any question, please put it in the chat, or you can raise your hand. If not, then we can move to our panel discussion. As Kevin and Karina explained about the research priorities, so today's topic for our panel discussion is how to research health systems capacity. There is a question. So, Karina, would you like to answer the question?
Yeah, sure. And it's a really good question. So it was all done in English. And so we definitely think that was one of the limiting factors, especially for Central and South America, that we hadn't had translations into Spanish or Portuguese in order to have a better reach in that region. So it's definitely a limitation that I think we'll try and take forward. But yeah, definitely.
There is another comment from the participant. I can read it out for you. Interesting that priority did not include defining and focusing on children most at the risk of mortality from pneumonia, such as prematurity, family history of asthma, poverty, air pollution, malnutrition.
Yeah, for sure. And so this is something, just so everyone's aware, that the manuscript is currently under review, and this is something that we've brought up in the discussion, that the major risk factors for pneumonia mortality weren't really the focus of the research. The research priorities that came out were much, much more around how we can better diagnose, how we can better use vaccines to prevent, how can we better treat those cases that already happen, instead of those broader social issues. And kind of the reason we think that might have happened is, first of all, that those risk factors are so well established that maybe people think that we don't need to establish them again, but also that they represent such broader societal and political issues that they weren't relevant to the pneumonia specific agenda. So those are kind of the two reasons that we've hypothesized as to why those didn't come out. But I definitely agree, it's kind of highlighting this issue of the biggest risks we're not really trying to address. We're trying to address the issues of preventing the physical disease rather than the conditions that cause the disease. So I definitely think that was an interesting finding that came out.
Thank you very much, Karina. There is another one for you, Karina.
Yes, so this is being recorded.
Yeah, Karina,
so this will be shared. Just to say, so the publication is currently under review. So we're not sharing the whole list just because, 99% sure it won't change, but just in case. So as soon as that publication comes out, we'll be sharing that very, very widely on all the Every Breath Counts forums as well.
Great, thank you very much, Karina and Kevin. Let's start with the panel discussion. So today's topic for panel discussion is, again, as Karina mentioned, how to research health system capacity for childhood pneumonia, what can be doing better, and what learning do we have from the oxygen response to COVID-19 pandemic. We have a wonderful panel with us today. Let me welcome Dr. Jahan, the head of pediatrics at Al Khan University in Pakistan, Mr. Lufesi, the head of ARI at the Ministry of Health in Malawi, Ms. Bagayana, a biomedical engineer working with FREO2 Uganda, and Professor Lanetta from Nutritional Research Institute in Peru. And we are very sorry that Dr. Irimo will not be able to join us today due to recent bereavement, and we extend our deepest condolences to her and her family. The need to understand health system capacity to diagnose and manage childhood pneumonia is a persistent research need. Listed in the top 10 priorities in both 2011 Rudan list and once again in the current priority list. COVID-19 has really highlighted this gap in our knowledge for one component, which is oxygen. At the start of the COVID-19 pandemic, there was little evidence on the scale of oxygen gap, inadequate tools for monitoring oxygen access, and a poor understanding of what solutions are most suited to different settings. So this discussion will focus on how we can fill this research gap and what we have learned from this oxygen experience, and how do we fund longer term sustainable research needs. Dr. Faiza, I will start with you. Dr. Faiza from Al Khan University. You know that pneumonia mortality burden in many ways is a proxy for there being a well-functioning resource and accessible health system. Is it helpful to single out research into the capacity to manage pneumonia and not aim to have a whole systems view of capacity?
Thank you so much, Yasser, and thank you, Kevin and Karina, for that great talk. So I think it feels that we are going to do a lot of discussion around health systems. And, as a clinical pediatric ID, I'm very passionate about pneumonia. And it is absolutely true that in academics, when we discuss the disease and the issues around it, we mostly focus on, diagnostics and better implementation of treatment modalities. But the truth is, that we, even for the things that we do know about, we have not been able to implement them with the scale and magnitude that we would like to, and with the quality that we would like to. So when you look at the government, at the government level, at all three levels, and I'm talking about countries like Pakistan, India, Bangladesh, that hold a high morbidity and mortality of pneumonia. So at all the three levels, primary care, secondary care, tertiary care, we can do much better in fulfilling all of the gaps that are related to the integrated management of common illnesses. And pneumonia is one of the IMCI, one of the focus of the IMCI management. There have been several gap analyses from South Asia, and the most recent one was from Bangladesh, Dr. Campbell, and where we saw that, basic things. So absence of having functional ARI timers, absence of pulse oximetry, absence of injectables for those with severe disease, absence of IMCI service registers, even in the district hospitals, the oxygen availability was low. It was at most at 60%. So this clearly shows, and this is just one report, years and years and years, we have seen that there are health system deficiencies. And we need to break down this problem of health system. When we say health system, it's a big, huge beast. We need to break it down into the different pieces. What the referral is, what the center is like, how are they presenting. So we need to break it down and have an integrated approach to managing the illness. I know that the priority exercise did not really bring up, things like we mentioned, and there was that was a great comment in the chat, by the way, that, we're still not addressing air pollution, prematurity, malnutrition. We're not addressing the gap in immunizations. So as we do this, I still personally feel that, that health system part we need to cater and we need to address, but we also need to continue our quest for diagnostics. We are really in the molecular era and in the omics and the genomics era, and COVID has actually brought in so much investment. And so these are the two sort of extreme areas where I think that we need to work around. I hope that answers the question, Yaqub.
Excellent, Faiza. Thank you very much. You have highlighted a key issue of oxygen and implementation at scale with the quality of care also. So I will continue with that with you also, that we know that oxygen crisis, which has been long known as a challenge for childhood pneumonia, has been accelerated and thrown into the spotlight by COVID-19 pandemic. Do you think this will promote more collaborative research going forward? And should we be pushing for less silos funding that is not pathogen or condition specific, but treatment or system focused?
Yes, it's a great question. And again, when we prioritize health and we prioritize what we have, it is best that we have an approach where we are putting all our forces together for a collective response. In the entire COVID-19 pandemic, I think there have been excellent examples where oxygen supply and oxygen equity has been achieved in many countries, and I think Pakistan to a certain extent did pretty well in terms of that. But even in Pakistan, our actions were very reactive. So we do need a more dynamic and proactive stance as we move forwards. Oxygen has been on the WHO essential medication list for a long time. And it is really high time that we expand this funding to improve its use case, not just for specific diseases like COVID-19 or childhood pneumonia, but have a more holistic approach. And one such example can be the EECC, which is the Essential Emergency and Critical Care, right? So the Essential Emergency and Critical Care package is a care package that is providing quality care to critically ill patients in the hospitals in the world. So we can add the funding to this EA. It can benefit not just the critical patients of those hospitals, but also the ones who are not that critical, but who require oxygen, and specifically children with pneumonia who are hypoxic. So I think we need to package oxygen with all the other essential requirements. And this will ensure that, whatever funding we put in, it just goes a long way. So absolutely, I mean, the answer is yes, we should be incorporating rather than, developing simultaneous tracks for funding around addressing the oxygen challenge, incorporating within the current current processes that are going on.
Thank you so much, Faiza. It's a really good discussion, and keeping this discussion forward, I would like to move to Ministry of Health representative, Mr. Norman Lafesi from Malawi. Lafesi, welcome. And I have one quick question for you. What do you think are the challenges in understanding health system capacity for pneumonia management in Malawi?
Thank you so much for this great question, and I will try to answer that question. I've worked with the Malawi government for some time now, about 20 years, and all those 20 years I've been working on pneumonia, especially in children. And we have consistently worked with different partners, and I know that the global platform sets the pace of what is going to be done in different countries like Malawi. The first challenge I would say is that we had been having Malawi as a government in their positions. We have been having people who have not done much research and their program managers, they are dealing with a different research, and it becomes difficult for us to interpret the research. And after not failing to interpret the research, and we have also failed to make sure that we have failed to make sure that we can turn that research information into action, which mostly is lacking in the different countries. As many research done in Malawi, Malawi is good at doing research, and it has been done mostly by people from different countries. And when the research has been done, most of the times they are being done by experts from outside, not experts from within. So I think one of the challenges for us to pick research into policy has been that of knowledge and also expertise. And most of the times we lack dissemination of research results in a simpler manner, which everybody else can understand. That's, I think, one of the major challenges which we have been having. The second challenge which we have been having is that to understand, pneumonia, mostly they depend on oxygen when they are critically ill. And mostly it has been, oxygen has been a problem globally for pneumonia patients and as well as other patients. So now I think what we have been doing is I've been an advocate for oxygen since I started work on pneumonia. And I remember one time celebrating, the whole government celebrating receiving 5 oxygen concentrators. 5, I mean, which I think is a terrible thing. I think which I think we need to create more awareness that oxygen is a drug and oxygen is needed for every child who is having breathing problems. So I think that's one of the challenges. And as I said, the global pace sets the national pace. So you remember in the year 2000, we had IMCI, and when we looked at IMCI, it was focusing on children and the children who are not specifically critically ill at the hospital. We ended up giving antibiotics, but not giving oxygen in our guidelines. So once we had that, not giving oxygen in our guidelines, we neglected the hospital care. I know in Malawi, we did not neglect that. We worked with the International Union Against Tuberculosis and Lung Diseases in some district, most of the district hospitals, and we reduced the pneumonia mortality by great heights. So I think if we have one of the major issues, the global pace, once they go with the global policy, once the global policy has been set, many governments follow that. It's not easier for the governments to not to follow WHO guidelines, not easier.
I think there is some internet problem with Mr. Lefesi.
Yeah.
Was the question.
Yeah, he's back. Mr. Lefesi, we missed some of your last conversation for a minute or so due to internet connectivity.
Yes, I was saying that the global policy sets the national policy. It is difficult for countries not to follow what UNICEF is writing, what UNICEF is saying, what the WHO is saying. So it is important that when we are setting these guidelines and policies, we really focus on what is really important and what is the really most important thing for pneumonia. I know for oxygen, we have been fighting for oxygen, and we are always thankful to the US government for putting oxygen as a priority to this. That's what I was saying. So I was just saying that the most important barrier which I've seen is what the global sets needs to be interpreted well by the governments in different governments. So as the IMCI was interpreted as a binding policy, then most of the critically ill patients were neglected. So that's, I think, what I would say now. Thank you.
This is wonderful, Mr. Lefesi. All your points are good. My next question is, do you think COVID-19 will improve this situation? The gaps which you identified?
Okay, fine. My best answer will be yes or no.
Mm-hmm.
Yes or no, because it depends on how governments, how experts in the government and NGOs, international organizations, make sure that this opportunity of COVID-19 should be taken as an opportunity, not as a threat, because COVID-19 has revealed the weaknesses of our systems. For example, in Malawi, what we have just done, we have put in 2 critical documents. The first one is the roadmap to oxygen roadmap, where we have described what we want in Malawi, what is current trend need. So we are in need of oxygen plants. We need oxygen for everybody else in the hospitals, and we make sure that this is going to be helped, and this is going to help the whole system, because oxygen is a system issue, not a one patient's disease-specific issue. So we are taking this opportunity as that. The second document which we are putting in place and we are going to launch soon is the emergency and critical care strategy. I remember the first speakers talked about neglecting emergency and critical care services in the countries. We need to strengthen these emergency and critical care services. So what we are looking at, we are thinking that we should implement a system which is comprehensive enough and trying to pick everybody at all levels. So the emergency and critical care strategy is going to pick that. So we are taking the opportunity of COVID as an opportunity to strengthen our system. I said no, because if we just take COVID as a threat, it will depend on the response by the government, by the experts in the government to say, this is the direction we are taking. If they are taking a wrong direction and they're taking COVID as a threat, then it will be a trouble. So that's why I'm saying we can improve systems if we take it positively and strengthen and take a route to strengthen our systems. So that's, I think, the route we have taken in Malawi, and we hope that we are going to be successful. Thank you.
Excellent. I think all your points are very well explained, and we have learned a lot from you as an implementer, because we always say Ministry of Health, and we would like to listen those challenges and how we can address those challenges in the field. So thank you very much. Now I would like to move to Ms. Shela Bagayana. As someone who works across the innovation to implementation spectrum in oxygen systems, what are the biggest health system challenges you face when moving from innovation to scale up implementation? I think this is very relevant question, keeping in mind Pfizer's comments and Mr. Lefesse's comments. So Shela, over to you.
Thank you so much, Mr. Nisa. It's really a pleasure to be able to share some of the challenges we faced as we are trying to implement from innovation to implementation of different oxygen systems. So I'm a biomedical engineer, currently working with FREO2 Foundation as a Uganda country manager, where we've developed oxygen systems specifically for low resource settings that are more suitable for the environment and can continuously provide oxygen even in a challenging situation, such as power cuts, low maintenance, and you're able to continuously monitor the systems. So in our path to implementing such systems, of course, we've been faced by a number of challenges. And one is very similar to what my brother from Malawi mentioned, is policy. So there's a very unclear policy, especially even right from the innovation space, especially in low resource settings. Of first of all, what's the procedure of testing some of these devices that have the potential to actually provide solutions to some of the challenges we see now, but there is no clear pathway. And this is very clear. There's no guidelines from Ministry of Health on testing, on implementation. So this usually takes us out a really long process, of course, engaging quite a number of stakeholders and delays the process immensely. One other thing that I can think about is, of course, the regulatory approval as well. So we may know that developing a device oxygen devices, respiratory devices. Of course, the process is long, yes, but also the getting is not easy, and it's also a very expensive route to take. And that also brings me to the financial aspect. So even when you develop something that's you think or you have proven that will actually reduce the costs of a facility if implemented immediately or in the short term, there's such a long way between actually developing, testing these, and actually you actually getting it to the facility to do what it's supposed to do. So I think those are some of the challenges we've faced so far. And another challenge has been competing priorities. So when we started, say, our work in Uganda, that was in 2016, of course, COVID has currently played a really, really big role in improving the way people view oxygen from the government, the Ministry of Health, but even hospitals and health workers. So when we started in 2016, you'd say, oh, I want to bring oxygen to this facility. And people would say, oh, what about blood? Oh, what about malaria? Oh, what about HIV? So there would be all those, say, conflicting interests, but we have tried to kind of work with different partners and just draw the need for us to all work together, because somehow all these things are interrelated. As we're providing oxygen for pneumonia, sometimes to malaria who need oxygen, and it's a holistic approach to build and to promote. So I think those have been some of the challenges that we have faced. And of course, in trying to build sustainable systems, we have to take into context both the social, the economic, and the impact, of course, on the health of the people. So in doing this, there's so many things that we take into consideration, say in terms of sustainability. How are people going to be able to manage these devices, to maintain them? How are we going to create an ecosystem where we can cut down the maintenance cost of some of these devices that has been, and these are some of the things that have been a huge hindrance to access to oxygen.
Thank you very much, Ms. Bagayana. These are all very, very important points and challenges you have discussed with us. So my next question is, as a service provider, how best do you effectively engage with the health systems in which you work? And how do you ensure you have actively get involved in their research agenda?
Thank you so much. I think that's a very, very interesting question. So one of our biggest approaches is staying on ground. So getting real feedback from the real clinicians, the patients, the caregivers, and seeing how they interact with the systems, the technicians. So we have tried as much as possible to maintain or to have real-time feedback and from ground, and also real-time. So we try something, if it doesn't work, then we shift and change. So quickly innovating, changing, trying, testing, and seeing what works, and then that's how we've been trying to move. Another way is engaging with various partners. So of course, one of the things that came out from the research was for us not to work in silos. And at 302, I think that has been our biggest goal, to work with as many people as possible to implement some of the things that we are able to do. For example, we are currently partnering with Brick by Brick Uganda, which already has established a number of neonatal ICUs. So just collaborating with them and coming together and say, we are not good at NICU care, but what is that provide oxygen? How do we work together? So just working with various stakeholders. Another thing we're doing is in the process of implementing our systems and our oxygen programs, we do collect a lot of data, valuable data. I know that it came out that sometimes we know what to do, but this is not actually being done. So what we are trying to do is to push facilities to actually use this data that we are getting from them. So on a monthly basis, we go back to the facility and say, these are the number of children who had hypoxemia who visited. These are the number of children who were not able to get oxygen. So how can we work together? Do you need any of this data to convince anyone if you need more funding for your facility? So that's a kind of proactive approach that we are trying to engage health facilities using real-time data so that they can be a better place to make decisions that will benefit the facility and the patients. So I think those are some of the things that we've done.
Excellent, excellent, Ms. Nishela. These are all very important aspects, and your collaboration with different teams to be involved in implementation is absolutely marvelous. Now we move to Professor Lanetta. Given your experience on international panels and task forces in child health, are you surprised to see this research priority so highly rated? If yes, why? And if not, why not?
Well, first of all, thank you for invitation. I'm very happy to participate. You may know, but I'm a founder of the Child Health Initiative that brought all this methodology. I work very close with Igor Grudan in the first round of priorities. So I'm very happy to see that the work hasn't been forgotten. And I'm very happy that it has been upgraded with the current questions. And I think the results are very interesting. And I think I'm looking forward for the paper and the discussion that will be published. My first comment is that I'm not surprised at all. I think there are many issues that are still very relevant. If we, for instance, cover case management, yes, oxygen is a crucial issue, and everything that has been said makes a lot of sense. And I think COVID has given us the opportunity to make the case for making countries self-sustained and having sufficient plans to deliver oxygen to hospitals in a cheap way, and also all these oxygen concentrators that has been now available, they need to be produced more massively and in a more cheap way to allow at least every health facility that sees emergency cases to have oxygen available. I'm still concerned, something that we haven't changed, is the absolutely abuse of antibiotics. So even though we know that some of the pneumonia cases they need antibiotics, it is overwhelming, the amount of exposure to antibiotics. And we have highlighted at WHO the importance of antibiotic resistance as a new priority that needs to be addressed. And I think the pneumonia is one of the drivers. You cannot imagine how many people overtreat over the phone for just in case there is pneumonia without even examining the patient. And in developing countries where you can get antibiotics over the counter, it is a serious problem. The other problem that I don't think has been touched by even the first or the second round of priorities is the bronchospastic airways disease. I don't call it asthma because there's a whole issue between bronchospastic disease of the young child versus asthma later on in school age. And that is a neglected research topic. What is the managed and what is the best case management system is overdiagnosed as pneumonia, and many of those cases are really bronchospastic airway diseases. That's a group of children who has many times more than one pneumonia case per year, and it creates a significant burden for health systems, bronchospastic airway disease. So I'm surprised that I haven't seen that highlighted in the topics that has been discussed. Now, that's in case management. Obviously, neonatal divergence between high income and low income is a topic of discussion. And in my view, is a classical issue of transition. You know, when you are reducing infant mortality or childhood mortality, you start seeing neonatal health as a problem. When you are in that transition, you are still seeing childhood illness as the main driver of, health systems needs and care and so forth. But if you are successful in reducing infant mortality and childhood mortality, what you are left with are neonatal services that they need to keep growing. So that trend is going to happen. It's going to happen in whatever country makes successful approach to reducing childhood and infant mortality. So even though it hasn't been picked up by low-income countries, it's not to be lost in the radar screen that we are walking towards that scenario. And I think we need to address that as well. The next topic is vaccines. Absolutely, I have been doing vaccine trials since '84, and I'm highly committed to vaccines. And I'm a member of the WHO Product Development Advisory Group, PDBAC, that we review every year the status of vaccine development in the whole world. And our role is to give priority to those vaccines that are needed and nobody seems to be working, like strep A, strep B, RSV, and others. So I think vaccines are very well tracked. And I think both WHO and Gates Foundation, Wellcome Trust, and other groups, CEPI, are looking closely on what new vaccines are there. There needs to be further development, and hopefully we will soon have RNA vaccine for RSV and others that could make a difference. Even malaria is coming up. So vaccines, I think, are moving, and I don't think we need more priority to them. It's already recognized as an important tool. I agree with the comments on COVID. It's an opportunity. It's bringing a lot of attention to the weakness of the health systems and the importance not only to do something now that you have COVID, but remember, I mean, you can remember how much Bill Gates has been attacked by saying many years ago, we will have an epidemic, so much that people are thinking that he has created a virus. I mean, amazingly. We will have a new epidemic. We are very, very sure that a new virus will emerge sooner or later, and we will have the same bottleneck and the same problems that we are seeing with COVID. So this is an opportunity to establish good health systems, from the primary care to the ICU in most countries, and how to deal with such emergencies as COVID. So this is an opportunity to really foster health systems. And in that, why health system hasn't worked? I was in charge of a program in my country, half of Peru, 3,500 health facilities, 100 tertiary hospitals in the system. And we changed them in a year and a half, but not following IMCI or very vertical problems. I think there is still a major issue, even conceptually at WHO, that we are still thinking on verticality. Vaccines, vaccine programs. Nutrition, nutrition programs. COVID, COVID programs. And the description that Sheila was mentioning is real. When you walk into a health facilities, they're dealing with everything. What about malaria? What about HIV? What about pneumonia? What about diarrhea? So you need a comprehensive approach. And the way is not training. The way to improve that is management. How to organize systems. And we need a whole new approach of health systems. We did an accreditation system that was not for life. It was for every 2 years. We established 9,000 variables that changed the history of our hospitals. And we improved not only infant, but maternal mortality, 25 drop in the country in 2 years of the intervention. So it can be done. And we didn't increase the budget. It was not increased manpower, not increased health. It was just to organize and get everybody thinking, how can you do best or better with what you have? And there's tons of things that you can do better with what you have. And you need to organize systems, not just one health facility, from the big hospitals to the periphery. And that is lacking. IMCI hasn't touched that. It's still thinking that you are dealing with primary care only, and the big monster don't deal with that. It's too complicated. And that's exactly the reverse. If you change the big monster, it's easy to change the periphery. In the big monster hospital is where the brains of the doctors, everything is sitting there. And if you change that way of working, it will have a huge impact on the rest of the system. So I'm a strong believer of health systems, but you need a new approach, how to deal with that. And I haven't seen that at WHO. Nutrition, just to mention, I'm working Nutrition Institute. Don't forget micronutrients, don't forget zinc. Zinc has a key role on respiratory and diarrheal diseases. And finally, how to make all these changes. As it's been said already this morning, WHO is a leader. If WHO establish a policy, countries follow. And I have been at WHO from the beginning in the 80s, where the Diarrheal Disease Control Program was created. Then it was the ARI program was created. And they were very useful in doing research, in policy, training, advisory. It was well constructed. I think it's been lost a bit. And we need such a thing. We need a WHO not to create new initiative and somebody else is funding, is to really convince funders to give fund to WHO to do whatever is needed to come up with data, with good research, and with program recommendations. We're doing that for vaccines, but we're not doing the same for other action programs like pneumonia and nutrition and diarrhea, etc. So that's my final comments. We need that. And in that exercise, please do not forget that who makes decision at the country level is not our friend Norman, it's the Ministry of Finance. And you need to approach the Ministry of Finance with data. This disease is costing you that much. And if you do this, you will reduce your budget by this. And even I could help you with this donation. So you need to talk to the Ministry of Finance with money terms, and especially to their own budget, not to the world, not to DALIs, not to cost benefit analysis that doesn't translate to what it means to their budget. So I was in a meeting with the World Bank doing this, and I think that is badly needed, is how to change our policy recommendations with cost analysis that will have a meaning for each Ministry of Finance in each of the key countries we want to have a change. So I stop there. I have covered a lot of topics, but I hope that it will help the discussion. Thank you.
Yeah. Thank you so much, Professor Lanata. Your all points are very valid. And I'm happy that you are not surprised to see this list because all these are relevant still. Regarding IMCI is an integrated approach, and we are trying to make, as you mentioned, that Ministry of Finance should also be targeted. So we are trying to approach different discipline, because to prevent and treat pneumonia or any child health illness is a multifactorial or multi-sectoral approach would be the best. So thank you very much for your comments. Now back to your other component as a member of research community. What can we be doing different to ensure this research need is not still present in another 10 years time? What do you think about that?
I think you need to talk to the big players, no? I mean, no doubt about that. Gates has a key role to do, and you need to sit with Bill Gates and say, hey guys, don't think just on COVID, no? We need to do something. For instance, just to follow the COVID story, there is a group of viruses that we have forgotten, but they do exist, which are the beta coronavirus. And nobody has even searched for them. And it's a universal virus. So if we immunize for beta coronavirus, I'm sure you will have cross-reactivity to the new emerging coronavirus as we have seen it. You can see that you may remember that there was a blood bank samples taken from before the pandemic that were able to neutralize completely the SARS-CoV-2 virus. So there is immunity that has been generated by the beta coronavirus. So we could also do vaccines for them, and that's a neglected topic. Metapneumovirus. There are other priorities, and we need to convince Bill Gates, Wellcome Trust, the big players. I mean, the WHO will not be able to manage these topics. They need to foster the initiative to support this new initiative. And if WHO, I have seen that in PDBAC, if WHO says we need this, please act, and this is the kind of needs we have, they do respond. So I'm a strong believer that WHO has a key role in making things happening. If you put it in a nice way, in a nice meeting, and talk to the right people. That will be my response to your question.
Okay, thank you so much, Professor Lanetta. Yes, definitely. And one of your points, which I missed previously, about the specificity of pneumonia diagnosis, not giving antibiotics to everyone. Yes, we definitely need to make more specific diagnosis of pneumonia, including technology or laboratory investigation into like biomarkers and other stuff. So I would like to thank all my panelists, Professor Jahan, Professor Lanetta, Mr. Lefensi, and Ms. Bagayana for your excellent comments. Right from Faiza mentioned about implementation gaps and what are the key role in how we can improve those gaps. Then we moved to Mr. Lefensi, who mentioned about challenges and what challenges Ministry of Health in Malawi is facing and how we can improve them, and the role of COVID-19 as a mediator to do something extraordinary to strengthen the current health system. And then we move to the Ms. Bagayana. She also mentioned again the challenge from policy to implementation, which usually takes a longer time, because once you develop a policy, then you move to implementation and then trainings and moving to a last stage. And her involvement with the research team by getting the data from the field and using those data to make some decision is a vital thing, I think so. And then Professor Lanetta, thank you very much for highlighting the key issues around pneumonia, case management, vaccination, antibiotic use, bronchospasms, airway illnesses, and COVID-19 as one of the opportunity to improve the current and strengthen the current health systems, and involving donor agencies how to tackle these research questions. So thank you very much from my side, from the whole organization committee side. I would like now giving to the floor to Leith for closing remarks. Thank you very much. Over to you, Leith.
Great. Okay, thank you so much. So first of all, a really big thank you to our Every Breath Counts Coalition research co-chairs, the wonderful Dr. Karina King and Dr. Kevin Baker, who have overseen this multi-year, multi-country effort to come up with a list of research priorities for pneumonia that we can all rally behind. They've done it. It's about to be published, and we need to really put all of our effort behind it. Before I talk a little bit about that, I want a big shout out as well to you, Dr. Yassir bin Nisar, for your moderation, but also you're a real champion for this area of research within the World Health Organization. We depend upon you, and we're very glad that you're there. So thank you very much. And to our speakers, each of them are long-term actors in this area of pneumonia. They've been working year after year after year and will continue to, and we thank them for that commitment. I want to return to a key number, and this is the number that Dr. Michael Head and Dr. Rebecca Brown uncovered when they did a piece of research looking at what proportion of all infectious disease research is allocated to pneumonia. They looked at a 7-year period, 2000 to 2017, and found that over that period of time, there was $105 billion, a lot of money, spent on infectious disease research, but only 3% of that was allocated to pneumonia. Now, this is pre-COVID. So we were not investing in research in this area in terms of the burden, because pneumonia is 30%. Pneumonia deaths are 30% of the overall infectious disease deaths. So hold those two numbers in your head, 3% of spending on infectious disease research versus 30% of the burden. So pneumonia was underfunded going into COVID, and they exposed that. They also found that most of the pneumonia research is propped up by a handful of funders. 80% of them are in the US, and there are 5 of them. Let me read them out to you. The National Institutes of Health in the US, the Bill and Melinda Gates Foundation, the Wellcome Trust, the European Commission, and the UK Medical Research Council. Think of them as the big 5. These are the research funders that could do so much more in this area. So now we have a list of priorities, which will be published soon. And the Every Breath Counts Coalition is going to visit each one of these 5 funders and sit with them and show them the priorities and see if we can finally lift investment in this space that is more commensurate with its disease burden. I also want to quote something Michael and colleagues, one of their conclusions. They tried to explain why pneumonia has received so little of the overall infectious disease research pie funding. And they said this, and I want to quote it to you. They said, confusion over the definition of pneumonia, few experienced researchers to make a strong case to funders, and few high-profile public figures championing the cause have led to pitifully low levels of funding compared with the disease burden. So this is a problem they identified in 2019, actually, when they first published on this. And this is the reality that Karina and Kevin and all of you who are participating in this are trying to change. We want to make that statement untrue over the next few years. So we need your support for that. We're going to be calling on you all to rally behind these priorities in your individual discussions with research donors. Please make sure you're aligning your efforts around this list. And then joining with us. We will give you opportunities to come to meetings with us when we sit down with these funders in an effort to really get them to step up. I think COVID has shaken them all up because it is a pandemic of respiratory infection that we were ill prepared for. And we know that chances are we're going to get more of these respiratory infection pandemics. So we need much, much stronger body of research so we're not blindsided as we have been with COVID. A final remark from me, something we're very concerned about, and I commend Karina and Kevin for being very transparent about this. We have 2 different sets of research priorities, one from high-income country respondents and one from lower middle-income country respondents. They're very different. And the publication is going to show how different they are. What do we do with that when we sit down with funders? Do we prioritize the lower middle income country priorities? How do we explain why there's such a great gap? We're going to be coming back to you to have more discussions on this because we don't have a clear path forward on that. And women, we don't have enough women respondents. We know global health research is still dominated by men in the North and the South, and we need to change that. We know there are so many young women coming through our universities and in research institutions, particularly in low middle income countries, and we want them to be part of this and we want their voice to be heard. So we know those 2 areas we need to do more, and we call on you all as well to do more in those 2 areas. But that's it from me. We thank you very much. This has been recorded, so we will be able to share the recording with anybody who would like it. And also we encourage you to be in contact with each other on some of the issues that we've raised on this call and keep the debate and dialogue going. Karina and Kevin will also be back in touch with all of you as we move now after publication. We transition to trying to activate these research findings so we actually get what we're all looking for, which is increasing that 3%. I'd love to see it go above 10%. It's still nowhere near the 30% of the burden, but I think our internal goal will be to get that up to 10% in the coming years. So there's a hard target for us all to reach for, and we look forward to joining forces with you. So on behalf of the entire Every Breath Counts Coalition, we thank you so much for being on this journey with us. We're not done yet, but I think we can get there. Thank you very much.
Thank you all.
Thank you. Bye-bye.
Thank you so much. Bye-bye.
Thanks.
Thank
everybody.
you. Bye-bye.
Thanks. Bye.
Leith, I don't know if you had this 2 minutes just to debrief.
Yes, let me stop the recording now.